Good day, this is Dr. John Bennett broadcasting from Miami. Today we have another conference in the Conference of Pediatric Neurosurgery in the collaboration of Neurosurgical TV with the Department of Neurosurgery of AIIMS Hospital with Deepak Gupta. Today we have the pleasure of having Sandip Chatterjee, MD. He's going to be speaking about Spinal Dysraphism. And first we'll introduce the guest. Hello, Slaven.
Hello, my name is Slaven Gojkovic. I'm a medical student at the Zagreb University in Croatia. I'm very interested in neurosurgery, and I'm currently leading the Dandy Neurosurgical Club in Zagreb and also the student chapter of the Neurosurgical TV. I'm looking forward to this presentation.
Okay, welcome, Slaven. And Deepak?
Hello, welcome Dr. Sandip Chatterjee on this novel platform, and we are very excited to have you here with us. Dr. Sandip Chatterjee is a very fine, accomplished neurosurgeon with a special interest in pediatric neurosurgery from India, with a huge amount of experience backing up his talk. Dr. Sandip Chatterjee, we look forward to listen from you.
Okay, welcome, Sandip. It's all yours.
Thank you, Deepak. I'm supposed to be talking today about our current understanding of spinal dysraphism, and I thought I'll club it with the word tethered cord. And what we'll do over the course of the next 30 minutes or so is to go over some of the fundamental understanding that we have about this condition. The first problem with this condition relates to terminology. We have a number of terms, and we really tend to use them synonymously, although perhaps that's not appropriate. Dysraphism itself refers to any malformation of the spinal cord. Unfortunately, we use it almost synonymously with the word tethering, which is an abnormal fixation of the spinal cord which restricts movement. And of course, there is the term OSD, or occult spinal dysraphism, which refers to the situation where there is a dysraphism, but there is no manifest abnormality in terms of the exposure of the spinal cord to the surface. And we'll talk about all this as we go along. The word tethering first. Tethering effectively means to fasten by a line which restricts movement. And a tethered cord really is a congenital or acquired condition where the distal cord, reed conus, is tethered. And this, of course, leads to neurological, urological, and orthopedic manifestations. That's really what tethering is. Something that is, or somebody that is fixed to a point. And of course...
Dr. Sandip, your slides are not moving. Can you just move your slides? We are still on the first slide.
Oh, my slides are moving on my presentation.
Yeah, click on the left column. You got to manually click on each slide. On the left.
Is that moving? Is that moving now?
Not yet, not yet. Click on the left column. Are you clicking on the left column of slides?
Okay, is that moving now?
No, not yet, not yet.
We see the first slide only.
Now?
Are you clicking on the left column?
Yeah.
Okay, click twice on the left column. Okay, try to go to the top, the slideshow. You see the option slideshow? And click on the slide. Okay, start again. It's okay.
Can you see that?
Yeah, we got all the slides out now. So you can click on slideshow at the top and then click on the left column.
Are you getting the second slide now?
Not yet. No, not yet. Not yet.
You should have a tab, upwards tab called slideshow.
You see it at the top of the page on the left. It says animations and slideshow. Click on the slideshow.
Yeah, that's what I'm doing.
Oh, you are, and then you're clicking on the column. It's not working.
No, this is the slide. This is the first slide. You got the first slide, right?
Right.
Have you got the second? Because on my slide.
Okay, move the column. Do you see to the right of the slides? There's a column to move with your cursor. You see?
Yeah, I know that. I'm moving on my screen. I think the slide's changing.
Okay, well, don't make the screen so big. You may have tried to make it too big. Sometimes that's one problem with the Hangouts. Sometimes when you make the screen real big, the slides won't move. Unfortunately, it's a problem.
Can you see the slide sorter image on your
Yeah,
screen?
we can see all the slides now. If you want to if you want to click them one by one, that's fine. We could try that.
Is this working?
Okay.
Yes.
Yes, it is.
So shall we stick to this? Because I think there's a problem that you don't see it when I go into slideshow.
Yeah,
You
it's
see
the
the
problem
second
with.
slide now?
Yes, we do.
Okay, so shall wait, this is this visible? Then we can stay on this format.
Yeah, this is good.
Okay, fine. So just to go back and
Okay. And we'll edit
revise.
this up. We'll edit this out.
Yeah, so this is all right? You're on the screen?
Yes.
Okay, great. So just to recap what we said about the terminology, dysraphism refers to malformation of the spinal cord, whereas tethering is a fixation that restricts movements. This tethered cord, therefore, is a congenital or acquired condition where the distal conus is tethered, leading to various neurological, urological, and orthopedic manifestations. And that's the sort of equipment that you use for tethering. Now, if tethering is to fasten by a line which restricts movements, and a tethered cord is a congenital or acquired condition where the distal cord is tethered or stuck, leading to all these manifestations, then this implies that a tethered cord must have either a thickened filum terminale, or a conus which is below the normal level, or an abnormal tensile strength of the filum terminale, or any of these in combination. But before we go into what is an abnormally low conus, we have to know what is the level of the conus. Can you have tethering with the conus at a normal level? And is tethering a radiological diagnosis or a clinical one? Just to go and understand where the normal conus is, there has been a huge amount of controversy as to where the normal conus is when. And in fact, it was only in 1989 that it was first confirmed that the newborn conus is at the level of L1, L2, based on MRI scans. We know embryologically, between POD 20 and 42, there is the embryological phenomenon that we call retrogressive differentiation, which means, fundamentally, that the caudal cell mass gradually moves up to join the bottom of the neural fold. And there is a slow rise of the conus between POD 42 and week 20 in the embryo. In fact, I say there was such a lot of controversy about the level of the conus because long ago it was Mapson that reported that the normal conus level at birth was L4 and that it only ascended to adult level at L1. We now know clearly from MRI and from autopsy studies that the normal conus, in fact, is at L1 at birth. And this has implications when we're going to have to define a newborn with a tethered cord. This is the first publication using the word tethered cord that came out from the Hospital for Sick Kids, but by one of my previous ex-bosses, Harold Hoffman in Toronto. And this was the article he wrote, and this was the term he used, the tethered spinal cord, and suggested the protein manifestations associated with this condition. In fact, the first account of a dysraphic spinal cord was published long ago in 1857, and where Andrew Johnson reported about a fatty tumor arising from the sacrum of a child connected with the spinal membrane. Even a few years later, in 1892, this article, published by Virchow in German, Die Dame mit der Pferdamane, which means the lady with a horse's tail, was published to show a child who had a tethering lesion. The first publication in the BMJ in 1891 reported a child with a spina bifida occulta who had no paralytic symptoms until the age of 17. At this point of time, the spine was trephined and pressure symptoms on the cauda equina were relieved, and apparently this led to neurological recovery as documented in this publication. And this was the first publication which showed that if you had a tethered cord and you could somehow untether it, unfix the bottom of the cord by some means, then the neurological symptoms could reverse. The real problem of the word tethering, of course, I think is a linguistic problem. Because although we have so much literature using the word tethering, there isn't really an equivalent to the word tethering in any language apart from English. And that has led to a lot of authors, particularly the Japanese, interpreting tethering in a way which is not the way that Harold first described it. So if you have tethering, which means you have an abnormal fixation of the cord, you can have an abnormal fixation of the cord by an inelastic filum terminale, and this obviously means that as the cord ascends, you have a deterioration of the functional status because you have stretching of an inelastic structure. And the abnormal fixation of the cord, by definition, does not necessarily have to be only at the bottom. Here is a child with a Chiari malformation, which is a tethering condition at the top of the cord, which again can lead to similar manifestations as you can see in the syrinx, in the cervical cord, documented on the photograph on the left. Amazingly, tethering seems to have a geographical distribution, and this is the UNICEF map documenting where cord tethering and dystrophic spine conditions are common, and you will see that India, as well as the eastern half of the United States, it seems to be far more common than, say, for example, in the western half of the United States, or indeed in China. So that's fundamentally the concept of tethering, a low conus and a thick filum terminale. The next question, of course, is in these dystrophic children who have a tethered cord, is untethering necessary in all cases? And there's a beautiful article published in Clinical Pediatrics in 1995, the title of which is self-explanatory, which says, referring to untethering in dystrophic spine, it says, standard of care, the blind leading the blind. And in conclusion, it says to accept the standard of care without subjecting it to clinical studies is dangerous. It cannot be accepted that surgery is mandatory to prevent neurological deficit. So let's go back and look at the pathophysiology of tethering. What exactly happens in tethering? First, we've said there is interference with normal ascent. This results in the cord getting fixed, causes distortion, stretching, and leads to traction injury. And we know that long ago in 1957, it's been demonstrated that this tethering affects not only the cord, it affects 5 segments rostral to the point of tethering. In fact, in 1981, through a series of beautiful experiments, Professor Yamada was able to show that there is impairment of the mitochondrial oxidative mechanisms in 3 to 4 segments of the cord above the level of the tethering. And we've also had documentation that after untethering, the cord blood flow increases, not only at the level of the tethering, but also the levels above. So pathophysiology of tethering is not only stretching, there is pressure, there is ischemia, and there is, of course, cellular metabolic impairment. And the neurodeficits that you get in dystrophic spines which have tethering is due to the true tethering, it can be due to the mass effect, and it can be due to dysplasia. Let's try and understand the embryology that causes the dystrophic lesions. Fundamentally, there are 3 defects that occur in embryology that leads to these lesions. You can have defects of gastrulation, which is the formation of the three layers of the embryo. You can have defects of the two neural folds getting together, the defects of primary neurulation, and of course you can have defects of secondary neurulation. Interestingly, Professor Yamada has the most scientific classification of these dystrophic tethered lesions. In type 1, which he calls category 1, there is a true tethering, as is witnessed in this child with this lipoma of the phylum, seen here on the right in the operative photograph. So this is a condition where the spinal cord is tethered because there is a lipoma in the phylum which holds the cord down. The type 2 tethering, according to the Yamada classification, can be a type 2A when there is a compression. There is an element of compression because, for example, here you have a dystrophic lesion, you have a big lipoma, which is also causing compression on the underlying cord and therefore necessarily a certain degree of ischemia. And type B of category 2 is when you have signs above it, like you have in this syrinx, which you can document above the level of the tethering lesion here. And the type 2 it manifests because there is not only compression, there is ischemia, and there is abnormal attachment, as you can see in this operative photograph of a chaotic lipoma. And type 3 of the Yamada classification is a dystrophic condition where there is lack of neuronal contents. And here is a large meningomyelocele, and this, of course, the problem is a formation of the neural elements. So you have either a neural element which is stretched and fixed, you have a neural element which has something on it which is compressing it, or you have inadequate neural elements present. And all these three classify as dystrophic lesions leading to tethering of the cord. And this is an example of, again, type 3 Yamada dystrophic condition, where you see that there is a lot of abnormal tissue and a very thinned out cord. So why is this classification of dystrophic and tethered lesions important? It's important because in type 1 tethering, for example, in the lipoma of the phylum, the patient will improve, both the pain and the neurology will improve if one goes in and does an untethering procedure. In type 2A, remember this is the one which has a compression but no changes proximally, there will definitely be pain relief if one goes and addresses dystrophic condition. But neurological change is by no means guaranteed. But in type B, when there is compression with proximal changes and ischemia, you're likely to get both neurological and pain relief. Whereas in type 3, the type which does not have adequate neuronal elements, you're unlikely to have any predictable improvement. So, where do these conditions fit in? A tight phylum terminale is type 1. A split cord malformation can be a type 2 as well as a type 1. A dermal sinus is always a type 1. A lipoma and a meningomyelocele, depending on the anatomy of the lesion, may be a type 1, type 2, or type 3 lesion according to the Yamada classification. And therefore, there are some that will improve and there are some that will not necessarily improve with surgery. So just to sum up the dystrophic conditions again, you have the disorders of primary disjunction, the lipomas. You have the disorders of secondary neurulation, like the lipomas of the phylum. You have the disorders of gastrulation, the split cord malformations. You have the disorders, again, of incomplete disjunction, which causes the dermal sinus. And, of course, the disorders of secondary neurulation, which can cause a number of manifestations, including a dermoid. And the clinical manifestations of these conditions would be orthopedic, urological, or neurological. Another type of classification that we've heard traditionally of dystrophic lesions has been open and closed, depending on whether the skin is continuous and intact over the lesion. Read that the cutaneous ectoderm is developed normally and the neuroectoderm is not exposed to the surface. And of course, the open ones are the meningomyelocele and the dermal sinuses, with the others being classified as the closed dystrophic conditions. And we've already talked about the presentations. What investigations does one do with a child with these conditions? Of course, the postnatal investigations include X-rays. The prenatal investigations include a maternal AFP in the neural tube defects, the ultrasound scan, which can be done even postnatally, the MRI, sometimes the urodynamics, and the neurology, the neurological status by doing SSEPs and other electrophysiological studies, which we rarely use. Of course, the ultrasound prenatally diagnoses this condition, as in this child quite often. The MRI is very useful, and you can see really the very abnormal condition in this child, where you have changes proximally, you have a tethering lesion, you have a lipoma here, and of course you have vertebral anomalies as well higher up. And sometimes, of course, you can just get a very discrete lesion like this. You can see the cord split here, you can see a lipoma, and you can see a tethering element with a lipoma outside there as well. Of course, the external manifestations can be very variable, and you can have big lesions like this or very small lesions. How do you treat patients who have dysraphism? Well, of course, if symptoms exist, symptoms progress, they need surgery. There's no controversy about that. What happens if there are no symptoms or signs? The so-called asymptomatic dystrophic lesions. The first big problem when dealing with this definition is, of course, in the word asymptomatic. What is asymptomatic? Bladder symptoms in a 4-year-old? What about symptomatic static infant, an infant who's born with a fixed deformity which doesn't progress? So that's symptomatic static, as opposed to symptomatic progressive, which means a child with a dystrophic condition who develops a neurology in terms of a mild foot weakness, which over the next few months progresses to a weakness of maybe the leg with loss of sensation in the sole of the foot. So we're really, when we talk about asymptomatic, we're talking about asymptomatic completely. We're talking about asymptomatic but static, like a child born with a little minimal neurological deficit which does not progress. And of course, the symptomatic progressive. And the real debate about all these conditions and whether one should operate has stemmed from the fact that we've not really separated these three categories. And the test case, of course, for the asymptomatic dystrophic lesion has been the conus lipoma. And it's been the conus lipoma because the logic is that if it is asymptomatic, surgery is to be considered or not. Now, if one has to say that surgery has to be considered even if the dystrophic lesion is asymptomatic, then number one, the surgery must not produce any deficit. Number two, this surgery must prevent further development of neurodeficits. And number three, it must be established that waiting and watching can cause further increase in size, leading to more tethering effect and more neurological deficit. So in other words, we have to prove that simply waiting and watching the lesion is detrimental, in the sense that operating late produces worse results than operating early. Is that the case? Well, of course, we know there's a whole lot of literature which says that definitely there is a chance of a lot of neurological deficit in the asymptomatic conus lipoma. And the literature has shown that the rate of neurological deterioration in asymptomatic lipomas of the conus after surgery has ranged from 4 to 16%. What about halting further neurological deterioration? Well, do we really know what is the cause of neurological deterioration in these dystrophic patients? Do we have evidence that the delay causes progression of symptoms? This is one of the cases from Professor Ali Pirkan's report from the Children's Hospital in Paris. And they were the first ones to say that this is not true, because he showed that in the Paris series there were patients who at 58 years came with the first symptom, had their first MRI at the age of 60, and the first neurosurgical consultation at the age of 62, thus showing that there may be a group of patients with dystrophic conditions who do not have any manifestations till they are very much older. So what is the rate of growth, for example, of a lipoma? We know that in an external lipoma, it grows 20% in 5 years. And we can extrapolate that this may be true for a lipoma of the conus as well. There's a huge lot of literature about the pros of prophylactic surgery versus the cons. These are the pros and cons of prophylactic surgery. These are the cons of prophylactic surgery. And the arguments of those people that advise not operating on dystrophic conditions which are asymptomatic has been simply this, that we do not know whether there is a spontaneous clinical recovery from any neurological deficit. We do not know the long-term results of surgery. It's difficult surgery, it is risky surgery, it can produce neurological deficit. So for a small tethering lesion like this, which is asymptomatic, the whole group, led by the group from Paris, has always suggested leave well alone. They've gone on further to prove that in almost a fifth of their patients, untethering was not possible completely, and that 20% of their patients developed problems like pseudomeningocele after surgery. And this is the famous graph from the Paris study, which showed that the time to clinical deterioration after surgery seemed to be almost worse than the natural history of patients managed conservatively. So the conservative versus the surgery patients did not seem to show a significant difference in the two groups. And this led the Paris pediatric neurosurgeons to suggest, particularly in lipomas of the conus, there was no justification in operating on patients who were asymptomatic. The Vancouver study, published a few years later, disagreed. Of course, it disagreed in many ways, disagreed with the rate of postoperative neurological deterioration, and it also felt that deterioration is unrelated to the surgery performed. And of course, currently, there is the Pang contention of Professor Dackling Pang, who has identified this white line which separates the lipoma from the cord, and who has shown very clearly in his studies that there is a huge difference in the outcome in patients who have a total removal of the lipoma versus those that have had a partial removal of the lipoma, thus showing that in his own series, like in the Paris series, where there was partial removal of these lipomas, the results were very bad compared to those that had a complete removal. So where we are with this conus lipoma as an example of a dystrophic lesion is today that if it is asymptomatic, the results are good of prophylactic surgery if you can operate on them and remove the lesion completely and completely untether the cord. If you do it partially, then you're unlikely to improve over the natural history of the condition. Here's just some quick examples of other dystrophic conditions. Here's one which we used to call our cervical meningomyelocele, where you have a thick skin, intact neurology, and if you really look at these children, they have a fibrovascular stalk which connects it to the spinal cord. And of course, this was what we used to call a cervicodorsal meningomyelocele. We now know these are in fact limited dorsal myeloschisis, and you can clearly see there is a connection between this lesion and the cord with this stalk. The exact embryology of the limited dorsal myeloschisis is outside the purview of this talk, but it is worth pointing out that these patients need this stalk to be dealt with right up to its entrance into the pia, and therefore the recognition of this dystrophic condition, the limited dorsal myeloschisis or LDM, is fundamental to the understanding and the treatment. Of course, you can have a number of dystrophic conditions rolled into one. Here is a split cord malformation with enterogenous cyst in the same patient. This is a patient of ours, and you can see there is a dermal sinus with a dermal sinus tract, and this, of course, is an LDM, and there's a split cord malformation. And this child had two tracts, and the histology of the dermal sinus showed it was lined by epithelial tissue. The histology of the LDM showed it was lined by neural tissue. And that's what excuse me, the MRI look like. The lipomas of the phylum, of course, the case that I showed you before, a disorder of secondary relation, a dystrophic condition, which can be dealt with easily. And of course, you have these conditions, the neuroenteric cysts, where there is an abnormal connection between the amniotic cavity and the yolk sac, which persists into postnatal life. Lots of complex dystrophic conditions have also been seen by us and described by us. Here's a complex type 1 split cord malformation, and you can see there is not only a lipoma, a dermoid cyst, but also a neuroenteric cyst in the same child with a split cord malformation. Or this rather unusual dystrophic lesion, this child presented very late with features of abdominal problems, constipation, and you can see what this child has. That's an anterior sacral meningocele. That's a big dermoid cyst. And these are dystrophic conditions which are difficult to diagnose because there's no manifestations in the back, but relatively easy to treat. And this, of course, is an example of a lipoma. And you can see this huge lipoma with the cord terminating, and you can see intramedullary extension of this lipoma into the cord. That's the post-operative image of the same patient after tethering. And you can see what we've basically done is disconnected this cord from the lipoma of the skin and produced a nice big sac for the conus. So there are, in fact, a whole lot of dystrophic conditions that we can describe, but time is short, and this is just to give you an idea about the principles and concepts of tethering. Of course, the surgery for these conditions has become a lot safer because of the fact that today we are able to use neurophysiological studies. We are able to do nerve monitoring. We're able to record EMGs and do motor evoked potentials. So when we're dealing with this, and this is a chaotic lipoma, we're able to separate out fibrous strands from nerve roots during resection. And I'll just end because it's 29 minutes and 30 seconds, just telling you some of the reviews on tethered cord and dystrophic conditions. One of some of the excellent reviews that have been published in recent times. Here's one from the Jerry Oaks group in Alabama. This is a very beautiful article that Professor Hal Rickage wrote some years ago, describing the exact pathophysiology of these dystrophics that had tethered cord with spinal cord traction, vascular compromise, hypoxia, and metabolic derangements. And of course, more recently, we have a lot of literature on the ultrastructure of the phylum terminale as one of the reasons why these children with dystrophic lesions do deteriorate. Thank you very much.
Okay, very good. Thank you very much, Sandip, for an excellent presentation. Great photos, great slides, well organized, and a view into this part of pediatric neurosurgery. Any questions from the panel or comments?
Yes, if I may start, one of the main topics that interests me as a student who is, how can I say, hoping to be able to have a career in neurosurgery is pediatric neurosurgery, and I'm really a great fan of Professor Hoffman. I have been following his works. I mean, on the conjoined twins separations that he did with Dr. Rutka, and I'm really honored to be able to hear his disciple talking today. And I think this is one of the best presentations we had on Neurosurgical TV. I really hope that you will be able to do more presentations like this. With this, how can I say, I have made so much screenshots just to make sure that I capture all the literature that you mentioned, and I will really use your presentation as a review of this topic. And I do have a question for you. Can you please take a bit more time and tell us something about your experience with Professor Hoffman? And also another question, if just shortly, briefly, is in the whole area of pediatric neurosurgery, how important do you find spinal dysraphism surgery, and where would you put it in this area? Thank you so much. I hope.
Yeah, I think the first. If I was going to answer the first question and tell you my experiences with Harold Hoffman, that would take up the rest of the evening. So I won't do that. I think you've read enough about him to know what he's been doing. But he was the first person who actually had this concept that there is something happening. It's not just the fact that you have a bit of neural tissue protruding out of the back without skin cover. It's a little more than that. It's the fact that this spinal cord is stuck somewhere, and that the entire blood circulation and metabolism of the spinal cord and in fact the tracts proximal to this lesion is being affected. I think that was really he was one of the first persons to think of it in that way. And that was a great thing. In terms of where dystrophic lesions stand in the whole spectrum of pediatric neurosurgical conditions that we see, well, I just showed you the UNICEF slide, which tells you that there are certain parts of the world it is still very common. Of course, open neural tube defects, by and large, are getting less and less, and we really definitely see less open meningomyelocele today than we saw 15, 20 years ago. Having said that, the other dystrophic conditions, which are the closed ones, the lipomas, the split cord malformations, I think these are getting identified a lot more quickly because we have prenatal ultrasound, which makes the pediatricians very, very prompt in getting postnatal MRIs on these neonates. And of course, there's a lot more awareness. The other thing that has developed is these children with spinal deformities, I mean bony deformities, get investigated very early. They get MRIs, and that picks up a lot of tethering lesions. As you know, scoliosis in children often presents with tethering lesions like split cord malformations, and we certainly have a huge number of such children that we deal with as well.
Thank you so much for your answers and experiences. I enjoyed. Thank you.
Thank you.
Deepak, do you have any comments or questions?
All I want to say is congratulations, Dr. Sandip. It's a very explicit and a complete presentation on feathered cord syndrome. Thank you very much.
Thank you, Deepak.
So you did a year fellowship with Dr. Hoffman in Toronto. He's obviously a well-known expert in this area. Did you spend a year fellowship, or you just visit him, or what did you do with Dr. Hoffman?
No, I spent a short time as a fellow in sick kids, and that's when I had a chance to see him.
Okay, very good.
That was his last days, in fact. So it was.
Oh, okay. Okay, Sick Children's of Toronto. That's a pretty good hospital.
Yes,
it's a pretty well known one.
If I may mention, there is a nice documentary that can be found on YouTube regarding the Professor Hoffman's separation of conjoined twins, which were craniopagus, vertical craniopagus. So I think it is called. I will try to find the name, but it is really an amazing video which shows. I mean the spirit of Professor Hoffman. So I think really it is famous personalities represented in this conference today. Thank you.
Are you operating now, Doctor, on these defects?
Yeah, very much so.
Okay. Do you get a lot of referrals from the area?
Yes, very much so. We see a lot of these children, and also we have a very well-developed department of spinal deformity surgery, where we have orthopedic spine surgeons that deal with children with spinal deformities. And when they do MRIs on these children, they pick up a lot of dystrophic tethered lesions, particularly split cord malformations. Mm-hmm. And therefore, we get a lot of referrals from our orthopedic colleagues who get these children as scoliosis, and then they're found to have a various number of dystrophic lesions. Of course, you need to tackle that first.
Okay, very good. Okay, this wraps up the conference, and it's a good one to have for the last. Thank you very much, Doctor. We hope to see you in the future.
Thank you very much indeed.
Thank you.
And sorry about that hitch with the slide.